Let me paint you a picture. You're 74 years old, you feel great, you're sleeping well, your energy is decent, you're doing things you enjoy, you go in for your annual physical, routine, nothing special. Your doctor glances at your chart and says, "You know what, let's run a few tests, just to be safe." 6 weeks later, you're sitting in a surgeon's office. Not because anything was wrong with you, but because those just to be safe tests found something. And that something set off a chain of events that your body at 74 was not equipped to handle. And now the life you were quietly enjoying, it looks very different. That exact story plays out more often than the medical system likes to admit. And the data behind it deserves a serious conversation. My name is Dr. Franklin, and this channel is dedicated to one thing: helping adults over 60 understand what the research actually says about their health in plain language. And what I'm about to share doesn't come from a single textbook. It comes from years of studying the medical literature and paying close attention to what the evidence shows when the system runs on autopilot. Here is the truth that most doctors won't say out loud in a 15-minute appointment. After the age of 70, some of the most common routine medical tests can cause more harm than good. Not because medicine is broken, but because the risk-to-benefit math changes dramatically as we age, and nobody is doing that math in the room with you. Today, I'm walking you through 5 specific medical checkups I would personally reconsider after 70. I'll tell you why the math changes, I'll share what I've seen happen to real patients, and at the end, I'll give you a set of questions that will completely change the dynamic in your next doctor's appointment. Stay with me through all 5. Because number 3 has stopped many people in their tracks when they first hear it. And number 5 is the one that most people have never even heard of until it's too late. Before we get into this, I'd love to hear from you. Where are you watching from today? Drop your city or country in the comments. I read every single one, and it really helps me see who's part of this community. All right, let's get started. Before we get into the 5 checkups, I need to give you one concept, because without it, nothing I'm about to say will fully make sense. I call it the longevity lens. When you're 50, screening medicine works beautifully. You find a problem early, you treat it, and you potentially buy yourself 30 more years of healthy life. The investment is worth it. The math is clean. But here's what changes after 70. 3 things specifically. First, many conditions detected by routine screening in older adults will never actually harm you. They grow slowly, they cause no symptoms. You will likely outlive them. But once they show up on a report, medicine doesn't have a leave it alone and watch button. It has a treatment button. Second, your body's tolerance for intervention drops with age. The surgery that a 55-year-old bounces back from in 2 weeks, that same surgery in a 78-year-old can mean months of recovery, complications, loss of independence, or worse. Third, there is something called the cascade effect. One test finds a small abnormality. That triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, a person who walked in feeling perfectly healthy is navigating a medical nightmare. All started by a test they didn't need. That's the longevity lens. Keep it in your mind as we go through each one. Before we begin, take a second and tell me your name and where you're tuning in from. I go through the comments and I genuinely want to know who I'm speaking to and supporting here. Checkup number 1, routine colonoscopy. After age 75. Let me tell you about Dorothy. Dorothy was 77 years old, a retired librarian from rural Tennessee. She'd had 2 colonoscopies in her 50s and 60s, both completely clean. No polyps, no family history of colon cancer, no symptoms whatsoever. But her new primary care doctor looked at her chart and said she was due for another one. Dorothy did her research. She had concerns, but she didn't want to seem difficult, so she went. The prep, the liquid you have to drink the night before to clear your bowels, hit her kidneys hard. By the next morning, she was confused, dizzy, and barely able to stand. Her daughter rushed her to the emergency room before she ever made it to the procedure. She was severely dehydrated and her electrolytes were so dangerously low her heart was at risk. Dorothy spent 4 days in the hospital. She never had the colonoscopy. And the irony, she didn't need it. The United States Preventive Services Task Force, the gold standard body that sets screening guidelines in this country, officially recommends against routine colonoscopy screening for average risk adults over the age of 75. The evidence is clear. After 75, if you have no symptoms, no family history, and clean previous scopes, the risks begin to outweigh the rewards, and those risks are real. Bowel perforation, a literal tear in your colon, occurs in approximately 1 in every 500 colonoscopies. In a younger adult, that's a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, a colostomy bag, extended hospitalization, and a recovery that fundamentally changes your quality of life. Meanwhile, the colon cancers most likely to be found in asymptomatic older adults tend to grow slowly enough that in many cases, they would never cause problems in a person's remaining lifetime. What to do instead? Ask your doctor about a non-invasive stool-based test like the Cologuard or annual FIT test. These can flag genuine warning signs without the procedural risks, and if you do have symptoms, blood in your stool, unexplained changes in bowel habits, that changes the equation entirely. See your doctor. Checkup number 2, aggressive PSA prostate testing and annual mammography for low-risk patients. Let me be very precise here, because this topic deserves nuance. I am not saying never check for cancer. Cancer screening has saved millions of lives, and it can absolutely save yours. What I am saying is this: after 75, aggressive cancer screening in average risk, asymptomatic individuals has a serious overdiagnosis problem, and overdiagnosis leads directly to overtreatment. Here's what overdiagnosis means in plain language. Imaging technology today is so sensitive that it can detect cancers that are, biologically speaking, barely awake. Tiny, slow-growing tumors that, left alone, would never spread, never cause a symptom, and never shorten your life. You would die with them, not from them. But the moment a radiologist writes the word malignancy on a report, the clinical machine turns on. Biopsies, specialist referrals, treatment decisions, all of it moves forward, regardless of whether the cancer actually poses a threat to you. Consider a case like Richard's, a 79-year-old retired mechanic from Georgia. Sharp, independent, still fishing on weekends. Routine PSA came back slightly elevated. Biopsy confirmed a low-grade, slow-moving prostate cancer. His urologist recommended radiation therapy. Richard trusted the recommendation. He went through treatment. Within a year, he was dealing with chronic fatigue, urinary problems, and a quality of life that had dropped dramatically. Stories like his are documented across the medical literature. Men who, looking back, wished they'd understood that their cancer was the kind a man his age would almost certainly have lived alongside, not died from. That knowledge, had it come earlier, might have changed everything. Studies in the New England Journal of Medicine found that a substantial portion of cancers detected through mammography in women over 70 were clinically insignificant, meaning treatment offered no survival benefit, only side effects. What to do instead? Have an honest conversation with your doctor about your specific risk profile. If you have a family history, genetic markers, or symptoms, screen. If you're average risk with no symptoms, ask your doctor directly, if we find something, what are the realistic treatment options at my age, and what would we likely recommend? That question alone often changes the conversation. If you're still here with me and finding this helpful, take a moment to type 2 in the comments. It lets me know you're watching and getting value from this. Checkup number 3, routine cardiac stress testing without symptoms. This one surprises people because it sounds so logical. Your doctor says, "You're 72, let's just make sure your heart is doing okay." You hop on a treadmill, or they give you a medication that temporarily stresses your heart and monitor the response. Sounds benign, sounds responsible. Here's the problem. Cardiac stress tests in people without symptoms have false positive rates that can reach 40% or higher in certain populations. That means nearly half the time, the test flags an abnormality when your heart is actually fine. But medicine can't just shrug at an abnormal finding. That false alarm launches you into the next phase, a cardiac catheterization. Catheterization means threading a thin tube through your blood vessels, typically through your wrist or groin, directly into your heart. It's a serious procedure. Risks include bleeding, vessel damage, arrhythmia, and in rare cases, it can trigger the very heart attack or stroke you were trying to prevent. And here's where it gets even more counterintuitive. If the catheterization finds a partial blockage, which is extremely common in adults over 70, many of whom have no symptoms whatsoever, you may end up with a cardiac stent. Multiple landmark clinical trials, including the widely cited ICE-Chem. So you've gone from feeling fine, routine test, false alarm, catheterization, stent, blood thinners, ongoing monitoring, and you are no better off statistically than someone who simply managed it with medication and a 30-minute daily walk. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during activity, routine stress testing is looking for problems in a population where problems are common and intervention doesn't always help. Talk to your doctor about optimizing your risk factors instead: blood pressure, cholesterol, blood sugar, activity level, sleep. That's where the real gains are. Checkup number 4, routine bone density, DEXA. Screening with automatic medication. Here's one that makes people uncomfortable when I bring it up, because osteoporosis is real and falls are devastating in older adults. So let me be careful. I'm not questioning the reality of bone loss with age. I'm questioning the automatic pipeline that often follows a DEXA scan result in patients over 75. A DEXA scan detects low bone density. Your doctor prescribes a bisphosphonate, medications like alendronate or risdronate. You take them for years, assuming you're protected, but here's what often goes unmentioned. Long-term bisphosphonate use has been associated with a rare but serious condition called atypical femoral fractures, spontaneous stress fractures in the thigh bone, the very bone you were trying to protect. These fractures can be severe and require surgery. Additionally, these medications are linked to osteonecrosis of the jaw, bone deterioration in the jaw that is painful and very difficult to treat. Meanwhile, the most effective intervention for preventing fractures in older adults, bar none, isn't a medication. It's fall prevention. I'm talking about balance training. Studies show Tai Chi specifically reduces fall risk by nearly 50%, removing tripping hazards from the home, installing grab bars, checking for medication side effects that cause dizziness, getting vision checked regularly, and ensuring adequate protein and vitamin D in the diet. These interventions reduce fracture risk more meaningfully than any pill with zero side effects. I'm not saying never take medication for bone health. There are absolutely patients who need it, those who've had fractures, those with very low T-scores, those with specific risk factors. But a routine DEXA leading to automatic long-term medication for an active 74-year-old who has never broken a bone and is otherwise healthy? That's a conversation worth having, not a foregone conclusion. What to ask your doctor? Before we talk about medication, can we review my fall risk factors? And what's the actual fracture risk reduction from this medication compared to a structured fall prevention program? And if you've made it this far and you're getting value from this, type the number 4 in the comments. It's a simple way to let me know you're here and following along. Checkup number 5. Asymptomatic carotid artery ultrasound screening. This is the one almost nobody is talking about. And based on what the research shows, it's one of the most quietly consequential. A carotid artery ultrasound checks the large blood vessels in your neck that carry blood to your brain. The idea is simple. If we find a significant blockage, we can surgically clean it out and reduce your stroke risk. Logical, right? The reality is far more complicated, and for asymptomatic patients, far more dangerous than it sounds. Here's the key fact. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the procedure. In older adults, especially those with other health conditions, that risk is higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults who have no symptoms, no mini-strokes, no vision loss episodes, no neurological symptoms. Their analysis found that in asymptomatic people, the risk of surgical harm outweighs the benefit. Here's why. Many people over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been there for years, stable, silent, not causing any problems. When you screen for it routinely, you find it, and then a well-meaning surgeon recommends fixing it. But the surgery to fix a blockage that was never causing symptoms can, and sometimes does, dislodge a tiny piece of plaque that travels directly to the brain. I'm not going to walk through a single case study for this one, because the documented outcomes are too significant to reduce to one anecdote. The medical literature shows people walking into a routine screening appointment and leaving on a completely different trajectory than they ever imagined. not because of the blockage that was found, but because of the intervention that followed. What to do instead? If you have no symptoms of stroke or TIA, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, then routine carotid ultrasound is generally not recommended. The far better investment is in controlling the actual modifiable risk factors: high blood pressure, the single biggest stroke driver, blood sugar, smoking cessation, atrial fibrillation management, and staying active. If you do have any neurological symptoms, even brief ones that resolved, get evaluated immediately. That changes everything. Practical framework. The 5-question protocol. I promised you something you can use, so here it is. Every time your doctor recommends a screening test, especially if you're over 70 and feeling well, I want you to have these 5 questions ready. Write them down, put them in your phone, bring them to every appointment. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to trigger unnecessary follow-up procedures, even if nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This forces the conversation toward outcomes, not just findings. Question 3. What is the procedural risk of any treatment we'd likely pursue? This is the question most people never think to ask. Every procedure has a risk. You deserve to know it up front. Question 4. What happens if we monitor this instead of treating it? For many conditions found in older adults, watchful waiting with regular monitoring is a legitimate and often superior option. Question 5. What is the most effective, non-invasive intervention for this condition? Because very often, as with bone health, heart health, and stroke prevention, lifestyle and medication outperform procedural intervention with far less risk. Any good physician will welcome these questions. They will respect you more for asking them. And if your doctor dismisses these questions or makes you feel difficult for raising them, that's important information about whether that doctor is the right fit for you. I want to close with this. There is a difference between medicine that finds things and medicine that helps you live well. After 70, the goal of your healthcare shouldn't be to generate findings. It should be to protect and extend your quality of life, your independence, your energy, your ability to do what matters to you. The best physicians I've ever known understand that doing less sometimes takes more wisdom than doing more. That recommending watchful waiting requires more courage than ordering another scan. You have the right to know what a test is looking for. You have the right to know what happens if something is found. You have the right to ask whether a finding would actually be treated and whether that treatment would genuinely improve your life. Medicine has given us incredible tools, but tools are only helpful when they're used in the right context, at the right time, for the right person. You are that person, and you deserve a healthcare experience that is built around your goals, your values, and your body, not around a checklist. If this video gave you a new way to think about your health after 70, please subscribe. I make videos like this every week, practical, evidence-based, and honest, to help you take control of your health in the years that matter most. And leave a comment below. Have you ever had a routine test that led somewhere you didn't expect? Your experience might be exactly what someone else needs to hear before their next appointment. Take care of yourselves. I'll see you in